Hi, everybody. It's Karen Anderson here with Aortic Hope. I am back. I'm excited to be here for this very special live Q&A with Dr. Stacy Fisher. And what we're going to do is kind of talk about all things aorta. We always tend to focus a little bit on BP and heart rate, but with the warmer months coming up, we should talk a little bit about how this weather impacts us. I know people have had some questions about exercise and recovery, and if they get dehydrated, and a whole bunch of different things. So please feel free to submit your questions in the chat here on this page. But before we get started, please click like, click subscribe, click that bell so that you're notified every time we go live. And we have some other really special thing we're going to do. So don't blink because you might miss it, but it's going to be still cool nonetheless. So Dr. Fisher, I'm going to let you take it over and introduce yourself to everyone.
Sure. Hi, I'm Dr. Stacy Fisher, and I'm with Johns Hopkins Hospital. I'm an adult congenital heart specialist and work a lot with aortic disease and genetic-related heart diseases. It's a pleasure to be here, and I look forward to hearing any questions that you guys have during this time as well.
Okay, warm months. Not this week. I don't know what happened. I just came back from Florida where it was like 87 and I was freezing at the airport, but it's coming. The warm weather's coming. And I know there's a lot of people, a lot of chat out there in the community about how the weather can impact us and our blood pressure. So I don't know if you want to talk to that a little bit about what it does, best ways to stay hydrated, things like that, how our BP might be impacted by the weather changes.
Sure. First of all, the biggest issue is hydration. So, hydration you really want to do, we are all 60% salt water. So if you're really sweating, you get a little bit of salt water. But in general, salt actually increases blood pressure. So if you think about it, if you're low in blood pressure, the first thing they give you is salt water, saline or lactated ringers, it's salt water. So we use that to raise pressure. And the reason that salt is unhealthy is because most Americans actually have high blood pressure, a tendency toward high blood pressure, and some of the other risk factors that go with high blood pressure. And the salt makes it even higher. So what we want to do is really cut the salt down so that we can keep the blood pressure controllable. The heat actually drops your pressure in a lot of ways because it relaxes the vessels. So for example, if you're in a hot tub, when you get out, you might feel lightheaded, dizzy, have low blood pressure in the upper part of the body. The vessels are dilated, all the blood is pooling in the lower part of the body. And especially if you have connective tissue problems, you'll pool even more in the heat. So you can get very low blood pressure. Symptoms of that would be dizziness. So we don't want it too low, we don't want it too high, we want it right in the middle. So hydrate. If you're sweating a lot, you get the hydration drinks. If you're not sweating a lot, you get water. But make sure that your volume in and out are similar, that you're urinating, that your urine is actually clear. That's the poor man's way to actually see, are you well hydrated? Nice clear urine. And also that, that you feel good, that your blood pressure's good. Everyone with aortic disease really should have and needs to have a home blood pressure cuff. If you're not sure, just check the numbers. Don't go by how you feel. Look at the numbers, just measure it. Your goal is really, 100 to 130 for the top number and 80 or less for the bottom number, but should still also be above, say, 50 for the bottom number.
Okay, so that's good. So you just said 50. So when it's the top number, I saw somebody the other day posted online that their blood pressure was like 86. I never got to the bottom number because my jaw dropped when I saw 86 as the top. When is the top number or the bottom number too low? And then we'll ask about too high.
So dizzy is the first answer. If you're dizzy, especially when you stand up and if your blood pressure is dropping, that's really important. If it's always running below, say, 90, that's usually in an area that you're not going to tolerate or that you could hypoperfuse other organs. So that's where you want to start thinking about bringing it up. And usually you feel kind of tired, washed out, just not good. So it's important that we also feel good, that we have enough to support the other organs, but not too high that it stresses the aorta. So the range I gave you really is a nice safe range for the aorta. 86 is getting to be a little bit too low. It's not frankly dangerous unless you're feeling bad, but you don't have any reserves. So if you took a hot shower, you'd be woozy, dizzy, feel bad. You could faint, you could hurt yourself. So that's where it is too low.
And don't go in the hot tub when it's 86.
We do try to push the medicines to the point that we protect the aorta, but we don't want to push them to the point that we're making you sick or not getting enough flow to the other organs.
So let me ask you, cold weather, what does that do to our bodies? If the warm weather relaxes the vessels, then what happens in the cold weather?
So it does constrict the vessels. And for example, snow shoveling, we don't like you guys or coronary patients snow shoveling because the vessels get constricted. And also people tend to overdo it and EMS can't get there. So that's why we really, it's the triple threat. That's the third part of the triple threat is the transportation and access issues. You can't get there. Your providers may or may not be there. A lot of people are here because they had good timing where the right person was there at the right time for them. And they had access to care. And that's not always the case in the really cold weather. But vasoconstriction can really raise the blood pressure. So it does matter.
Okay. All right. Getting back to warm weather, it makes me think of barbecues. And then it makes me think of people drinking alcohol because they just do. And there's graduations and people are drinking and weather and people are drinking. What does alcohol do, if anything, to our bodies and our blood pressure?
So it doesn't do a ton directly to blood pressure. It does directly affect the heart muscle. It is a direct cardiac toxin.
Oh, I didn't even know. Okay.
So in certain levels, it's okay. If you get above those levels, it really hurts the liver and the heart muscle itself, or the organ of the liver and the heart muscle itself, and as a direct toxin. So you actually can, in high levels, you can actually measure enzymes and see that you're causing injury. Okay. And depending on how much injury is, how much, damage you have. Usually a medical drink is a 6-ounce glass of wine, a 12-ounce beer, or an ounce and a half of liquor. And those are equivalent alcohol drinks for the most part, depending on the strength. Certainly if it's moonshine, it's going to be much higher. Or if it's 10% beer compared to 4% beer, you get a little more or less. But generally for women, 2 drinks, and for men, 3 drinks in a 24-hour period is a safe amount, but not every day. Okay. So if you use those guidelines, that's okay. That should work. But also look at the medications you're taking and talk to your providers about the medicines you're taking. And do they actually interact with alcohol? Some do more than others, where some may raise the level or slow the clearance. Or you may change your level or clearance of the drugs so that you have less efficacy or too much efficacy of your heart drugs. Okay. So that's where it becomes really important. The other issue with alcohol is rhythms. So there's something called holiday heart, where people go on a drinking binge and then they go into AFib. Wow. So it can actually trigger AFib. AFib is a common irregular heartbeat that can come from things like higher pressure or higher chamber size. It could be that somebody with an aortic dissection actually had very high blood pressure and that caused the chamber size dilation and the aneurysm, or that alcohol actually caused a heart muscle problem that made them retain fluid. Fluid backed up, caused the irregular heart rhythm, the bigger top chamber, and maybe weakened the aorta. So it can affect things in various ways depending on the regularity of the use and also the dose.
Okay. I've never heard of that holiday heart. That's
holiday
interesting.
Heart. It's not a happy holiday.
No, doesn't sound like it. But speaking of holiday, because we're into this warm weather topic, I also see questions from the community about vacations. So I don't mean to laugh. It struck me funny. Somebody asked today, if salt is such a problem in our diets, can we go into the ocean? And
that's a good question. And we used to tell people no, the calcium in supplements didn't matter, and it probably does. So that actually really does matter. However, we do not think that you actually absorb significant salt through the skin. Your skin is really a nice barrier protector. It should not actually get absorbed or raise your salt level in the body or have anything to do with the blood pressure.
Okay.
And
All right,
again,
well,
if you
that's
have low blood pressure, then you actually need a little bit of salt or a lot of
good.
salt. There will be people with something called POTS where their heart races, or orthostatic hypotension where their blood pressure drops too much, that actually really need to add salt to maintain enough fluid in the system. But
Okay.
many people have high blood pressure. So there are many more people with high blood pressure than with low blood pressure. In this group, there probably are an equal number.
Yeah, that's interesting. Okay.
Yeah.
So you're not really absorbing the salt water. So it's still good. So as long
Yeah.
as you can manage the waves, like ever since my dissection, my balance is not the way it was and my strength really. So I choose to like to go in the Gulf side where there's no waves. I like the baby waves. Okay, so going on the same questioning of vacations and holidays, air flying, can they fly? I don't know. I thought I read that the planes were pressurized at about 8,500 feet, but people get nervous to fly. They're nervous for blood clots. They're nervous something will happen with another, get another dissection or their aneurysm may rupture. What are your thoughts on that?
So in general, this really should not be a big factor for flying. The flying is more, people with pulmonary disease. So if you had significant lung injury, if you have oxygen issues, if you have a big smoking history, that's where you may have more trouble on the flight. If you are on oxygen or need oxygen or borderline for oxygen, definitely you want to have it available on the flight. Now there are portable types of oxygen you can bring that are FAA cleared, or you can pay for oxygen on the plane. Different airlines will have different policies on oxygen, but you can go online on the particular airline and look at which oxygen carriers are approved for them, or can you use their oxygen.
I never even know you could do that. That's amazing.
You can do that, but if your oxygen levels are normal and you don't have altitude sickness, you should never need to do that.
Okay. Okay.
So blood clots are important for everybody. People with aneurysm or dissection are not necessarily more prone to blood clots, and many people are actually on blood thinners, in which case you're going to be less prone to blood clots. So definitely if you have a family history, a different marker of blood clotting, then you're going to need to take extra precautions. For everybody, and especially if you've had surgery in the last 6 weeks before a flight, you really do want to move. So you want to at least pump your legs, right? Flex your feet back, get the circulation moving in your legs. Every 1 to 2 hours, stand or walk in the aisle. If you're short like me, you can actually just stand up and not hit your head.
Right.
That's the one benefit of being short is the airplane. If you're tall like you, Karen, then you're going to have a bigger problem. You have to go in the aisle.
I do.
So
There's just constant ducking.
Stand in the aisle for a minute. I hope the flight attendant, if anyone here is a flight attendant, thank you, and I hope we don't annoy you too much. But stand in the aisle for a minute, stretch your feet, or if you can't do that because of turbulence or it's just not safe, then at least massage the back of your legs for a couple minutes every hour, flex them a little bit. Support socks are a very good idea. If you're on a blood thinner, great. If you're on nothing, at least take a baby aspirin. If you've had a dissection, you're likely on an aspirin or on Plavix, on something already. But if you're not, go ahead and take a baby aspirin the day of the flight.
Okay. Well, you just led me right into my next question, because tonight we're just kind of bebopping, bouncing around because I'm so excited to get to the crescendo.
Do you want to fly?
Well, I just came back from flying.
Oh, I meant take a flight through
the thing we're doing in a little bit. Oh yeah, we're gonna do that in a little bit. Yeah.
Okay.
So this is another question people were asking. What is the difference? People just think you're only on warfarin if you have a mechanical valve. So what is the difference between warfarin, Eliquis, Plavix, and just baby aspirin? And why would somebody be on one versus another?
That's a good question, and they are really very different products. So aspirin and clopidogrel or Plavix are products that affect platelets, where warfarin or Eliquis, Xarelto, Savesta, or there's one more. they actually work directly on thrombin. So those, they're different agents. They affect different things. So thrombin is what actually is the endpoint of clotting.
Okay.
And a clot actually has a lot of thrombin in it. Things like thrombus in the wall of an aorta, or thrombus in the heart, or pulmonary emboli, or atrial fibrillation are more related to clot formation and clot prevention. And you actually have to affect thrombin to have an effect on those pathways. If you're worried about plaquing and plaque stability, where clot can form in plaques, such as coronary disease, where a plaque can rupture and close off the artery, or metal in the body, where a stent can actually clot instead of getting normal cells growing over it, then we actually need to work on platelets.
Oh, okay.
So, and what works on platelets is things like aspirin and clopidogrel, not so much the Eliquis Xarelto line of medications, or warfarin. So we're really looking at the underlying etiology of what we're trying to affect. If you have a device, for example, a mechanical valve, for whatever reason, and probably it's dosing, the DOACs like Eliquis and Xarelto have not been found to be effective or successful with those. We really only have warfarin for mechanical valves. They're carbon. They don't endothelialize completely, and they require a lifetime of coverage for the valve to prevent clotting on the leaflets themselves. At the same time, if you have atrial fibrillation without any implanted tissue, stents, material that you're trying to cover, the DOACs are actually as safe and effective, or more effective, than warfarin. If you have a thrombus, they're probably equal.
Okay.
So we have a lot of data in hundreds and thousands of people looking at these mechanisms of clotting, its safety of the drugs, the dosing of the drugs in particular people, whether we change it by their kidney function, their liver function. It's actually really important. And we do have a lot of different choices for antiplatelet therapy, not only aspirin and clopidogrel, which are most common, but also Praluent. I'm sorry, not Praluent, but Prasugrel, Brilinta, which is our most effective for stenting. So there are a lot of choices that are around right now, and particular people may have nuances where one is better than another, and the insurances also, are dictating quite a few of the choices of medications.
Yeah, and some of them can be quite costly.
They are quite costly.
Yeah. We do have a question that was just loaded up into chat. Individual has stenosis, 4.4 centimeter. They put AAA, so I'm going to guess that they mean their abdominal
aortic.
Yeah, and bicuspid valve. Really enjoys morning cold plunges and evening sauna. That sounds lovely. Maybe not the cold plunge. Well, maybe for me, if it was the opposite, if it was in the evening when the hot flashes come. Both make this person feel amazing. Any studies done on those practices with aortic patients doing cold plunge and then a sauna?
So not really. There are studies, done in general health especially with sauna right now, with good health benefits of sauna. Again, for an aortic patient, it's also going to matter how fragile you are. So if someone has a mild aortic aneurysm, no dissection, and not a high risk, they're not like right at the line of where they're considering surgery, then that's very reasonable, right? Also, the weight lifting restrictions are a little bit more flexible. If somebody actually has a persistent tear or an expanding area, then all of these hemodynamic stresses are more hemodynamic stresses. And, these are ones that are kind of moderate level stresses. So you're making decisions to have more stress to the aorta. It's not less stress to the aorta, right? It's more stress to the aorta. It may be relaxing or psychologically beneficial, but it's still going to be stressful to the aorta. So you're making a decision to balance your life preferences, quality with the aortic health itself.
Right.
And under surveillance, that's reasonable. And if you see worsening, you're certainly going to want to change your practices.
Right. Right.
But if it's
Yes.
stable and you're getting a lot of other benefits out of it, then that's a reasonable choice.
Right. Right. And that also brings us to exercise. That's a very, very popular, widely debated conversation in the community, because you have all spectrums. You have people on one end that are doing tough mutter races and jumping over barriers and swinging over mud pits and, doing triathlons, all the way to people that we can't even motivate to walk around their court because they're just almost cardiac paralyzed with fear. So when you're exercising, because we're trying not to, we would rather try to motivate those that are scared and help them understand that they should trust their physician when their physician says you can do this. And if they're really struggling physically, that needs to be a different conversation. But when it comes to exercise, what would be the ideal range? And I know that when you're done exercising, or at least when you're done, the recovery should end up being a little bit lower than when you started. Am I incorrect with that? I thought your recovery time, they shouldn't look worse, that's for sure. So maybe you can explain the mechanics of exercise and if there's targeted heart rates or blood pressure.
Yeah, so I think, the overall question is still something that you need to discuss on a personal level with your physician. Do you have a repaired aneurysm? Do you have a syndrome like Marfan syndrome or Loeys-Dietz, where you actually are at risk for other areas of aneurysm? Do you have an aneurysm that's expanding under surveillance? So there will be times where there really is not a perfect guideline for everybody here. However, in general, if we are not offering something like surgery or repair, it's because we think there's stability, right? And if you have stability, the stability should be where you should be able to tolerate a moderate level of exercise.
Yeah.
And always favoring the aerobic over the isometric. So we want the continuous increase in heart rate, but not intense. So we would like you to be able to have a short sentence that you can speak through exercise. You shouldn't be bearing down and holding your breath where you can't breathe or speak. You shouldn't be at a level where you can't speak, because then you're probably raising your afterload, jutting up your blood pressure for that period of time. So the hit and hills type philosophies really for this group it's not a good philosophy. Yeah. You really want a warm up, a cool down, a moderate level in the middle. We like you to go toward sort of 60 to 80% of age predicted maximum for exercise. However, that may be a much higher level if you're on beta blockers or you're on medications that blunt the heart rate, which we often recommend for people with aneurysm or dissection because they decrease the wall stress. So the heart rate may not be a great model to follow because we've medically blunted it. And a lot of people on beta blockers, for example, you see on your Apple Watch or your monitors that you have decreased heart rate variability. And that's because the medications blunt the variability some. Okay. It's not because you're unhealthy where you don't have that variability necessarily. So that's also just not a great marker as a goal for exercise or to monitor exercise. Okay. Blood pressure needs to be controlled. So that means it needs to be controlled. Either you have normal blood pressure, it's controlled with medicines. And if you're not sure, then an exercise test can actually tell you what your blood pressure is at different ranges of exercise and if it's actually controlled on your medications. So you can do an exercise test, either bicycle or treadmill with your physician, and figure out what is the right level of exercise where you still have control of the blood pressure at peak. It does generally, the top number will go up, the bottom number will go down in a healthy person, and then they come back together and drop below where they started after exercise. Okay. So the exercise blood pressure should not be static, it should change. You really cannot safely check your blood pressure while you're exercising well. There are new blood pressure monitors that are becoming more available that are patches that you can wear for 24 hours. that
Mm-hmm.
will give you your blood pressure over a 24-hour period. There's no cuff, there's no inflation.
Wow.
It's a plasmograph over the aorta. And that's something that you can actually wear during exercise at home and see in your daily life if you're well controlled. But it's only a 24-hour thing at this point. We're
Mm.
hoping it'll get a little bit longer too. And they're just becoming more and more accessible. So
Like, are they
that's,
accessible to general, or you have to get it through a physician?
um, I don't know yet.
Okay.
They are definitely available through physicians. However, the insurance coverage in some programs has worked out, most programs
Yeah.
has not worked out. We're actually investigating it right now ourselves to try to make it more
Interesting.
available.
Okay.
You can get them through online companies. I don't know
Mm-hmm.
that you even need a prescription, and the prices are pretty variable. So it's the
Okay.
beginning of the technology, but
That's
the
really cool.
technology is there. It's very cool. And as we get it more available, I'll bring it to you to show you.
Oh, I would love to try it.
Yeah, it's fun.
You know,
Yeah.
I'm game to trying anything. I love that.
Yeah, it's fun. And honestly, it's
Yeah.
going to be helpful in adjusting
Yeah,
medications.
absolutely.
Yeah.
So let me ask you a question before I take this next one that was typed in. Um, why do people need a cardiologist on their team? Because some people in the community only see their surgeon, thoracic, some people only see vascular, some people only see their cardiologist, some add in a hypertension specialist. There are all so many different roles. What do you think is the best team? And I know everybody's situation is different, but what would be the most important people and why to have on your team?
Yeah, I mean, I think for aortic disease, I think it's really important to have cardiac evaluation and see, do you
Hmm.
need continued care with a cardiologist or not? But you need at least a real evaluation.
Yeah.
And that evaluation is looking for concomitant heart disease related to vascular disease.
Okay.
So many types of aortic aneurysm and dissection are related to cardiac risk factors such as hypertension, such as atherosclerotic disease.
Hmm.
And if you have those, you have a high likelihood of having cardiac muscle disease, arrhythmias, or coronary disease. So being treated for secondary prevention to prevent events in the coronaries, heart attack and stroke, is critical. You can do that with your primary. You can just do a more focused look with your cardiologist. Things like echocardiography to look for other connective tissue problems, valve problems, muscle
Hmm.
problems, other congenital heart disease would be very important. Things like stress testing, for example, the question we just discussed, the blood pressure question,
Hmm.
that may be something that if it's easily fixed with your primary care, you're done. If it's labile, up and down, too low, too high, spiking when you're exercising, or you're getting arrhythmias related to the event, then that is something that you may be able to go to a higher level with the cardiologist.
Okay.
And again, it's going to be a more focused look at this system.
Okay. All right. We have
So
another
as far
question.
as
Sorry,
the
go ahead.
team, though, you
Uh-huh.
need a vascular or
Yeah.
thoracic doctor. If it's an ascending aneurysm or dissection, you need a cardiothoracic surgeon.
Hmm.
If it is descending, you need vascular.
Okay.
So that's actually important. Everybody, I believe, with a thoracic aortic aneurysm or dissection or familial aortic aneurysm should also consider a genetic counselor at least
Yeah.
once.
Yeah.
To look for things that they may be able to do to protect themselves and their family, and also direct screening in a more focused way as far as, why did I have this aneurysm or
Hmm.
dissection, and what could I do to screen better and be
Hmm.
smarter with the screening.
Right. No, that makes a lot of sense. Let's go to this next question. This is regarding someone's son who's 33, had an aortic dissection back in December. This parent obviously is trying to get an understanding after reading a CT scan report, which stated aortic dissection. I'm going to butcher these words. Okay. Aortic dissection originating at the proximal posterior margin of left subclavian artery to abdominal aorta. No aneurysm. It is what appears to be a small penetrating atherosclerosis ulcer at the base of the right, here it comes, brachiocephalic artery with associated focal intramural hematoma. He's being medically managed. Is this the normal treatment? And should he be taking low dose aspirin? What are the effects of a CT scan on the kidneys and overall health? Because he's seen a nephrologist also.
So basically, there's something called a penetrating ulcer, which is an area, it could be an area of trauma or plaquing or where a small aneurysm was that tore. And that actually tore in the aorta from after the subclavian, which is the vessel that feeds the arm, down. So it's called a type B dissection, meaning it's the descending thoracic aorta. And that dissection could have affected the kidneys itself if it went into the kidneys or if part of the kidney comes off of one lumen or the other. They're saying that there was not a big aneurysm, but it tore anyway. That can happen in certain connective tissue problems, or again, it could have started from this penetrating ulcer. That can also be an injury from a procedure. If there had been a cath or a surgical procedure, if you have trauma to the wall of the aorta for some reason, that can happen. And again, an early plaque could have done that as well. So it's going to be very important to work with the nephrologist. That's also a good reason to work with a cardiologist for screening. But again, the vascular surgeon's the most important. When you're talking about a dissection or tear, CT scans really do show you the best quality of the lumen. CT scans are tiny, tiny, thin slices. So you see very, very well the tissue. For screening for how big is an aneurysm and exactly what the extent is, an MRI is actually extremely helpful, but the CT is going to have a little bit more detail. The MR is magnet-based. It does not have any radiation, and the dye is more inert. The CT scan dye is an iodine-based contrast dye. Can affect the kidneys, especially if somebody has significant kidney disease or is in a pre-dialysis type position. After you're on dialysis, it doesn't really affect the kidneys. The risk is to injure the injured kidney. A healthy kidney will generally clear the dye without any issues. We don't like to overdo the dye, so if it's a lot of dye that's needed to see different things, we'll space out in timing the images. So for example, if you needed the brain and the chest, abdomen, pelvis all with dye, we would probably do one or the other and come back to the other. In trauma, we just do them all. So it depends what your risk is. You don't want to underscan. You do need to know if it's changing, right? So you also want to take you want to thoughtfully use the dye and radiation doses where you think they're best placed.
So let me ask you, when somebody has a CT scan and it says low dose, is that standard? And what does that really mean? Because people get concerned they're being dosed up with a lot of radiation.
Yeah, so the different scanners do have different doses of radiation.
Okay.
The other thing is that if you really want, if you have, for example, a big person, you're not going to get any pictures with a low dose scanner. If you have a lot of metal artifacts, you're going to have a lot of differences in the quality. So there's a lot of patient-specific things that may make you think that you're going to get a good enough quality with low dose versus using standard dose radiation. But there are a lot of protocols now trying to keep the doses very low, and the newer scanners do have lower dose radiation than the old scanners. And it does depend where you are and how urgent it is as far as what kind of input you have as to which scanner you're getting. And
can you still have good pictures and good results if you didn't give somebody the dye, or do you always have to have the dye?
So for the aorta, you can see the outside well without the dye, but the lining of the wall and the inside, you're not going to see as well. Okay. So if you're really looking for dissection and you need the exact lumen of the aorta, you really do need the dye. Okay.
And then what would be, I know it's hard to say, but life expectation or quality of life from someone who dissects from the aortic arch to the lower bifurcation?
So it depends on a lot of factors, right? And how good is the perfusion from different areas. The life expectancy after aortic dissection is not normalized yet. So we would like to say, oh, it's going to be absolutely fine, but you really do need to stay on top of it. You really do need to follow the restrictions given, make sure the blood pressure, cholesterol, everything's covered, and that you're also scanning for other areas of aneurysm or change. And then we are hoping that with these newer technologies and treatments and scanning to normalize the life expectancy. If there's kidney injury from the tear and one of the kidneys is not perfused or not salvageable, or there's a lot of injury from low blood pressures at the time of the tear, then there could be significant kidney disease, which becomes an important factor as well, both for medication clearances, for fluid retention and blood pressure control, and, for overall energy and stamina. So that can matter a lot too. And people have a lot of variability. So some of these you really do have to discuss with the providing doctors that have all the information. But it is actually really important. We do try to medically treat type B dissections. Sometimes they actually heal. Many times they will stay stable with blood pressure control. Many times a penetrating ulcer is something that actually gets unstable or penetrates because of blood pressure control. So controlling the blood pressure is critical. And sometimes you can see people go from intense pain to no pain, bringing the pressure down with some of the IV pressure medications in the intensive care unit during an acute event. So it's really important that this is treated and evaluated properly.
When you say heal, what do you mean when you say heal?
Somebody that has a penetrating ulcer, it can be a small flap right at the site that doesn't actually tear anywhere else, and it can heal.
Oh, okay. Okay, interesting. I would tell this person what you don't want to do is read Google life expectancy, because since I dissected, it's always said, forget 10 years, you'll be lucky if you can make it 5, which to me is just misinformation considering how everyone is being monitored now. We want everyone to be monitored, not just those with a known connective tissue disorder. And I think that to tell somebody you're not going to be here more than 5 years, knowing that you're going to, as you said, follow recommendations, continuously be monitored, look for any changes, and live a healthy lifestyle, I think that that is something you don't want to read, and you don't want to give any, don't put any weight in that.
Yeah, but you do much better with current technology and an aggressive care group. And if you have a very inexperienced group around you, look at the university centers, look for an aortic disease center. And definitely even use people in this group to find some of the providers that are more local to you, but don't be afraid to travel if you have to get a real opinion and real imaging.
And just so we do have a list. So anybody watching wants to know what might be in your area, we have compiled a list now. I think we're up to 440 medical centers across the United States. So if people ask us for don't give me a town, give me a state, because I don't know, I'm not a GPS, so I can tell you just everything that's in that state. It's just information we compiled. So I don't know anything about these hospitals other than I do know that they will treat aortic disease patients. So yes, you're right. And it makes sense to get second opinions, and you shouldn't be afraid to travel someplace else if that's what you need to do. So yeah. Okay.
All right. Very important, because there is a lot of access issues and variability. And sometimes even at the bigger centers, you'll have you'll have a change in the surgical team, or the interventional talents, may have changed places. And maybe they went into the community center across the street, and that's actually where you should be. So you may need to figure that out, but you may also need your doctors to help you figure that out. And it's okay to say, is there experience here, or do I need to go somewhere? And where is it around here that I need to go, wherever I am?
And you made a really good point, because it's not really the name of the hospital. It's the talent that's in that hospital, in that facility. That's what you're looking for. Names are names. It's who's actually in the facility, who's in the building.
Right. And what support do they have?
Exactly.
Do they have the ability to do the catheter-based technologies? Do they have access to the materials that they need? Do they have a team that will actually get them for you? Do they have the networking to bring these, these stents in? And there's a lot of variability in what's available.
Right. Right. Before we go on to all the exciting stuff that you're now doing, let me ask Joshua if there's any other questions or comments we need to get to. Okay, a lot of people. Hi back. Say hi back. Okay. All right. So then I'm going to turn this over to you to explain a little bit about what your role is now where you are and what we're about to see and how this came to be, because I'm just so excited.
Okay. So my role, I actually specialize in adult congenital heart disease, and we do a lot of pre-surgical planning for various anatomies, for things that are difficult to follow, or things that may be hard to see, or for trials of new technology where we're trying to figure out if technology will actually work in a particular structure, or if we need to do surgery where we don't have the technology available through the catheter. So there's a lot going on. And in aortic disease, there's a whole lot going on with things like endovascular procedures, where we need to actually understand the structures. And in aortic disease, some of the biggest issues is understanding where the branching is. Because no matter what, if you use a surgical technique, you can see what you're doing. If you use a catheter-based technique, you can see where the dye goes, but you may have a hard time seeing certain vessels, and you have to know ahead of time. I would rather the surgeon or interventionalist, which is not me, know what they're getting into and where everything is beforehand, hoping to help them avoid any anatomic variability. So one of those things is virtual reality or 3D printing. And we have done some 3D printing. Actually, I have shown some of our 3D printing aortas before, but today I'm going to show you a virtual reality little drive through Karen's aorta. So I'm going to share my screen if that's okay, and we'll go from there.
Be interesting to see my body part from the inside.
What do you see here?
I see your computer.
Do you see your aorta in the middle of it?
If you could have told me that was part of the Grand Canyon, I would have believed you. I'm not sure what I'm really looking at.
Okay, but do you see a computer with some vessels here?
I see three. I guess those are vessels coming off.
Okay, and you see my arrow, right?
Yes, yes.
Okay, good. So this is actually just to show you what we're looking at. This is using your CT on a computer screen using virtual reality software. So we've taken your CT and we have uploaded we have uploaded the data so that we can look at it in 3D. We have virtual reality head goggles on, like Oculus goggles or similar goggles. And we are in virtual reality looking at your aorta. So this is actually, and I'm going to stop it right here. This is the tear. So we have come up the ascending here. I have opened this up and taken this piece off of the outside. So this would be a closed tube, right? So this outside wall is gone. And we're looking in and we're going to go down into the dissection. But as you can see, it's actually torn. So this wall is intact. This wall is actually torn right here, and some clot is forming in here. And this is just before the takeoff of the great vessels. The great vessels are those that feed the right arm, and then the carotid arteries here and vertebral. So you can see that just before then it's actually split, and the split goes up into the great vessel here. And if I drive through, we're actually looking down the barrel so you can see the true lumen and the false lumen. Just so that you can see how the split works. So we can actually look, we can see where are those vessels. We can make a model and then we can print the model and we can try the endovascular grafts inside of the model itself. Or we can actually make a model in virtual reality of the device and bring it into this model and try to fit it so that we can try it in space before we actually try it in you.
Before you try it in me. Well, that's appreciated. That's pretty cool.
So it is pretty cool. So it's a lot of, it's been helped to bring a lot of insight into kind of what is it. And I was hoping with this that you could kind of understand, well, what the tear is.
Well, that's what I'm wondering. I am wondering, have you ever been in a situation with this that you discover something that maybe you never saw before on an MRI or a CT or an echo, where you're like, oh, wow, that tear is a little bit more extensive, or something just ends up looking, oh, I see me.
I see you too.
Oh, hi, that's odd. Let's not do that. Let's unshare the screen.
All right, I'll stop.
But have you ever found something that through this, it was like, wow.
Left.
Oh no, she'll come back.
She'll
right pop back in. Well, that was very cool. I think that technology seems really cool. Like, I want to go to the office now and put those goggles on, and I feel like I'm just going to be swimming through my aorta, Pretty cool. All right, she's back. Look at that.
So sorry.
That's okay. That's okay. I am curious to know, but have you ever seen something where you were like, that's not what we anticipated now that we're on the inside?
Yeah. So some of that is, for example, spinal arteries, where they actually take off, where the dissection really starts and stops. Sometimes it can be very hard to tell on the two-dimensional viewer, sort of where exactly the endpoints are, or if you have a clot that's affecting a particular spot, you really can see more.
Okay. So where did that dissection go into? I thought you said a great vessel. So
I only showed you the beginning of it, and it started right before the vessels that go up to feed the head and the right arm, and it went into the right carotid a bit. Just the beginning.
And I never knew that. It's new information. I heard that just now when you said it. My ear perked up because I said one time I think there was a radiologist one point that wondered that and said they saw that, and it was never written anywhere else. Not that I knew of.
Yeah,
but
so I think your repair went all the way up into the arch for that reason.
Oh, okay. See, 9 years later, and I'm still learning things about my own body. Yeah, I don't think I thought it was just my repair was just ascending. I didn't know it went into,
toward the arch.
Yeah, didn't know. It's very interesting. That's cool. Well, I see you not too long from now. I would love if you ever have an opportunity where I can put goggles on and see what it would be like. This is just like fantastic voyage. It's like
we will, but it takes time, and I don't have that set up for you quite yet.
That's fine. Whenever you say. I'm not going anywhere. I know where to find you. That's wonderful. I thought that was great. Yeah. Now I have a million more questions. Anybody else out there, Josh? I mean, it's a mid-spring evening and everybody was trying to find Aurora Borealis lights last night. They're probably outside thinking, finally tonight we have clear weather and we're not going to see anything here in Maryland. But anybody else have any other questions?
No questions.
A little bit quiet, but that is okay.
We've got a bunch of people hanging out.
Everybody's hanging out. I love when people hang out.
Yeah.
So now that you mentioned about genetic information, before we go, I want to talk about the genetic testing. With Think Aorta, one of the things that the two organizations try to share and explain to people is the importance of thinking about your aorta, thinking about your family medical history. So talk a little bit about the genetic component, and especially if whether something's been discovered in you or not, at what point do you begin testing anything on your children? At what age, and what kind of test would you recommend doing?
So importantly, the genetic testing should be done on the incident person.
Okay.
Right. So it should be done on somebody who's had a problem, and not somebody who's searching to see if they may be at risk for a problem necessarily, unless you're looking to do a broad panel. But in general, if you have something that runs in a family, if you can test someone who actually has the problem for the tests that we have available, then you'll know whether or not the testing is fruitful for the other people in the family.
Right.
So for
Okay.
example, if you have an aortic dissection, we would recommend testing you. If you have, there's 3 possibilities if you're testing for the current genes that we're testing for. One, that you have an abnormal gene or a spot on an abnormal gene that's actually causing the problem. Then we know a little bit better what else to test for, what other things might work. You're a candidate as it becomes more and more available for different types of directed therapies, hopefully. But also as far as testing, we recommend testing for first-degree relatives, parents, brothers, sisters, children. Depending on the gene and when the onset of the problem is, we may recommend testing at different ages. So for example, if you have something that's earlier onset in general than something that shows up in your 70s or 80s, we may recommend testing the younger kids. We always recommend looking at whole life insurance for kids before getting the testing, so that if in fact you have an abnormal gene, there's not a big chance that that's going to ruin their capability of getting life insurance, for example. And there are some gene protections, which is why we like for people to have genetic testing to make sure that with you in your life and your life planning, it's the right time for you to get your kids tested. And that can vary with different genes. So for example, for Marfan's or Loeys-Dietz type genes, there are a lot of other skeletal issues, eye issues, things that you would actually do differently if you were raising children that have those genes that may have increased susceptibility to other types of problems as well. So as far as taking care of the entire person, we would look at which gene you're talking about and what the comorbidities are and recommend some ages. It's also important to look at kind of the penetrance of particular genes. Some it's 50-50, some it's very rare, it's about 5% if they're recessive. So some are only on the X chromosome and will only transmit to female. Some transmit only on the Y. So it's really important to know exactly what you're looking at, who to test. But in general, for aortic disease, we recommend screening for brothers, sisters, parents, children. And as soon as you know what to test for, the other possibility of genetic testing is that it's negative, and that doesn't mean it didn't happen to you. It means that it either may not have a clear genetic pathway, or we don't know which one we're testing for yet. So your gene is not a more common or more one that we know of to look for. So the third possibility is the irritating one. It's called a variant of unknown significance. A variant of unknown significance is exactly that. Some of them will turn out to be pathologic. Some of them will turn out to be benign, but just interesting about you, like whether you have hazel eyes or green eyes. It's just interesting, but it doesn't change the quality of your eyes. So we're looking for things that change the quality of the tissues. So that's why there's a lot of variability in the recommendations. We'd recommend anybody with a dissection that isn't well explained by something like trauma or something like significant atherosclerotic disease where a plaque did tear or became a penetrating ulcer and tore.
Okay. And so if we're the people that have negative or a variant of unknown significance, would you, if you're not going to do genetic testing on someone's child or sibling, would you just at least screen with an echo just to get baseline aorta size?
Yeah, so I would screen with an echo if it's a thoracic aorta. And if you can't see, so echo is really wonderful if you can see. If you can't see the aorta, then I would look at a CT or MR for screening. And I think that it is worth doing that on the first degree relatives, which again are parents, brothers, sisters, children.
Okay. Okay. We do have a question that came in. Okay. It says something like, is that a blood test? Oh, has a question about, is that a blood test? Because is it a blood test for genetic testing? Because she has an ascending aortic aneurysm, and what kind of test would her adult daughters need?
So that's exactly what we're talking about. So it can be blood or it can be a saliva test or a cheek swab. So it's DNA and they don't need very much. And the testing then should be on you because you have the aneurysm. So if you have an aneurysm that's not well explained, and by explained, I mean in the setting of hypertensive emergency or for example, if you have a bicuspid aortic valve that explains the aneurysm, then the genetic testing is not so good for that, but the girls could have an echo to look and see if they have a bicuspid valve. So outside of an explained aneurysm, if you have an unexplained aneurysm, your adult girls should get an echo, and if they can see, then that's good, and then they would do it again about 5 years later. And definitely within a year of a planned pregnancy. If they can't see,
I was just going to ask. Yeah.
You know, if you can't see on the echo, then you would do something like an MRI or CT scan for the girls.
Okay. I was going to ask that, especially if they're going to be of age where they're thinking about getting pregnant. That's important. That's important. Okay.
Now, the other thing about genetic screening is that if someone is thinking about getting pregnant, say you have a gene, Karen, and your daughter, and I'm not calling your son a daughter, but it's say your daughter would like to get pregnant, they can get the gene tested. If they have the gene and no aneurysm and have decided to move forward with a pregnancy, she can actually have her eggs screened for the gene that is abnormal, and you can choose eggs that do not have the gene and do IVF for yourself with your own eggs without the gene. So that would actually screen out the gene, not only for your child, but their children and the lineage in front of them.
Yeah. Yep. It kind of just, the buck stops with you, basically. I didn't even realize that you could do that. That's amazing. That's amazing.
Now for men, it's harder. You can do embryo screening, but you can't screen all the sperm.
Okay. Right. Amazing. That is amazing. All right. Josh, any other questions, comments out there we need to know about?
And that was she says hers wasn't explained, and all my girls have all their kids already.
Oh, okay. All right. So yes, I think my son and I, I did a saliva test. He hasn't even been tested because nothing was really found in me. So he just got screened by you through echo, and that's the route I'm going. So yeah, I guess that would mean
and
that
then you would do it again about 5 years. And again, as the genetic screening gets better and better, right, we may decide to rescreen you.
Yeah, I've been screened twice.
Yeah, so I think, over 5 to 10 years, it will probably change. And actually, I think it's probably going to change faster because of AI, because AI is the one thing that, genetic testing really should be actually made much better with AI. Because there may be polymorphs, meaning you have a little bit of change in multiple different genes that actually can explain something like a weakness in the connective tissue. Just as much as a change in a single gene. And that's where our understanding of these things is very limited. But if you look at a whole bunch of population data, we might understand it much, much better with AI technology. So we're hoping in the world of genetics and even in genetic therapeutics that actually will make a big change. So that is where a lot of the research is going.
Yeah, that stuff is, that's where my head starts to hurt. And I say, just tell me where to be and what date and what to do. That's when I leave it all up to you. That's what you're good at, really good at. All right.
That's what a partnership is, right?
Yes, it really is. It really is. Okay. So I think that's all we have. We did it all within an hour. That was great. Thank you so much for sharing my insides, my aorta with everybody.
Thank you for allowing us to fly through. And I think it's a great way to see, exactly what you're talking about with the tear, which is to take a real CT scan and look at, what can you actually see? What are we talking about? How do you know it's really there? So there's someone in the emergency room with chest pain. How are we so confident that we can go to the operating room and that it's actually there? right?
Right. I promise you,
Because
there was new information on me tonight. I promise you. But what I also love is look, it's no secret. I tell everybody what's wrong with me. So I have a valve. It's probably going to need to be replaced. And I have two aneurysms. And it definitely makes me feel much more at ease knowing that this exists and that I have this feeling that my surgery, which will get to be planned, knock on wood, I won't have anything else that's an emergency, will be tailor fit for me. And there won't be any surprises when it happens. It should be very straightforward. If everybody's looked at it from the outside of my body to the inside of my body, there shouldn't be any surprises. So I kind of feel a little bit more comforted knowing that, actually. And we weren't talking about that 9 years ago. So,
no, not at
yeah,
all.
yeah,
Yeah.
it's
I mean,
amazing to
things are
see what's
changing
changed.
very, very quickly. They've also
Yes.
done a few ascending repairs in emergent situations with catheter-based devices.
See, so by the time I need it, maybe I won't even need to be cut open, which would be wonderful.
No promises.
And no promises at all, and I won't hold my breath. But there's always a maybe. I don't know.
There actually is a maybe.
There is a little maybe, but I'm not going to put all my chips on that red right now. No.
Right.
That's okay though.
Right.
But
And
this
the
is
other
still
thing
good.
is, some of it is timing.
Yeah.
Right. You
True.
need to live through the development of these things.
Yeah.
And if it's not quite developed, you want to take the best available the day you need it.
Absolutely.
Because you really do have to decide, when it gets to the point where you have to have it fixed.
Yeah.
You need to decide that it's really time and that you just need to do it. And you get a little bit of say in that, but some of it is out of our control.
Right. Well,
Right.
you know me, there's that part of me that's like, can we just do it already? I know. And then there's the other part that's like, yeah, no, it's not going to fit in with my summer plans. So we have to
Yeah.
just push it off again until the fall. Let's wait and we'll reevaluate in a few more months. So, but again, I like knowing that look what's happened in the last, 10 years. This technology I'm coming into it at a great place. And if I can hold off, if my body does what it's supposed to do because I'm doing what I'm supposed to be doing, who knows in 5 more years where things may be. So it's all, like you said, it's all timing. And I'm doing, as all patients should be doing, everything that's within their realm to do, because we can only control what we can. You once said to me, at the end of the day, we're still humans and our bodies, they're going to do what they want to do, despite all my efforts, despite all of the physician's efforts. It's still tissue. It's its own organ. So it's going to do what it wants to do at the end of the day. I can only control what I can control. So,
right. But part of the effort is that you're healthy in the background to take care of the things that are out of your control.
Yeah.
So that's a big part of the effort that shouldn't be underappreciated. So if you can really, do things to keep the weight controlled, the blood pressure controlled, the cholesterol controlled, the activity level good so that your muscles are strong so that you can get up after a procedure or a surgery, you're going to do so much better than if you're not doing those things and you're being a sedentary person like Karen's acting like right now.
Well, I can at least admit it, because the problem is I preach a lot of activity and I know that I should be more active, but my body tends to react negatively and is like, no, we're not going to do any of that today. I'm going to zap you and make you feel terrible. So it's how much of it is doing it because I'm under conditioned, or how much is my body reacting because it's truly reacting due to my valve or other structures. So it's my own self having to have confidence that I can do more than what I do, and that with the things that I feel aren't going to kill me, that they're new, just a big annoyance, but also the balance of listening to my body. So it's always a battle, and I'm always like, let's go back to PT and learn how to recondition myself with somebody there with me that I trust and, observing me. And I, every few months I go back in again and I try to make it happen. And it's doing it slow. Like you can't just jump into activity and think that I was in my 20s. I'm not. I am very much not. But, I'm also, and I'm very active in other ways. So me, I'm always going and here and there, but I do listen to my body, because there's many times, at least at some point every day, I'm taking a nap, falling asleep, can't keep my eyes open. And that's because I do get tired. My medicines are kicking my butt sometimes. But yeah, but I do know I probably could do more. I get scared like anybody else that's watching. I just got to balance it out. It's
Yes.
mental, it's emotional, it's physical, it's everything.
Yeah.
Yeah.
So
I'll get better.
slow and steady wins the race.
Yes, I'm a turtle. That's exactly what I am.
Slow and steady wins. Yeah, but it's true. I mean, you get up, you go, you do it at your pace. You try to improve your pace a little bit, and then you rest.
Right. That's
Right.
exactly
And it's
what
okay.
it is.
You actually do need the rest times. You need the
I do.
breaks, and then you get back up.
Yep. And you get back up. And then some days I do nothing, which we preach all the time. Doing nothing is still doing something because it just must be what you need. A good
Yeah.
day of, Real Housewives, just marathon it and rest. That's what you need. Until my watch says, all right, you might want to consider getting up now. And I listen to it and I get up and then it cheers me on. So
yeah, the wearable technologies are wonderful, honestly.
Yeah,
absolutely wonderful.
They are.
Yeah.
I know it thrills you sometimes when I'm texting you at 2 a.m. Look at what the watch is saying. I'm going to die.
It's making me look into some of those, like, I'm sleeping now.
Right. It's an automatic test. Stacy Fisher cannot take your text. She's presently sleeping, as you should be as well. Oh my goodness. Well, thank you again so much for giving your evening and teaching us. And wait, looks like I just got one more question. This person said, where I had my dissection, my surgeon does not have any in-depth interaction with patients after they save your life. How can I get more in-depth care and communication like you're giving Karen?
Right. So I am not the surgeon. That's really important. So the surgeons often will see you during your hospital stay, and then usually for post-operative care. And then often they release you back to your treatment team. And that's why someone like me, a cardiologist, who's going to be looking and helping with the surveillance, may actually be able to spend more time explaining and going through and helping with the surveillance, hoping to avoid you from needing to spend the time with the surgeon.
Right.
So that, again, is really, really important to have. You need a treatment team, and it may be a cardiologist. Certainly you want your primary care involved, but that is why it's worth having.
Yep. And I'll tell you, when I found my internist, I think I started with her maybe 2-3 years ago. Yeah, about 3 years ago. I hadn't interviewed a doctor since my son's pediatrician. So it was really weird to interview someone for myself, but I know the kind of interactions I need to have to be the best patient possible. And I really don't call doctors at all hours of the night. I mean, it's only once in a blue moon, but I know the accessibility that I need to know that I have to feel like, okay, I'm good. It's like a security blanket. And I also needed to know the accessibility as well. And my internist said, listen, you've got all these specialists. I'm just the spine of the book, and all the pages are everybody else you go to. So if you don't understand something, I can help, educate myself to educate you. If you need a phone call, I can do it. So we established our roles very early on what role she would play, because I hadn't had a general practitioner in years ever since this happened. There was no time. I was always addressing an aortic issue. So there is value in having your GP, and you just have to figure out what that value is for you in your own medical situation. But I will say, when I see my surgeon, we do have very in-depth conversations. When we do talk a lot, it's very personalized like this, but it is once a year. That's pretty much it. So the relationship with my cardiologist, which is Dr. Fisher, is very in-depth and detailed, because this would not be something I would be discussing with my surgeon. Medications or what my blood pressure is. I would be talking with him as I'm preparing, thinking about surgery. When he says it's time, we'll start those conversations. But the everyday type stuff is like this, and it's just a different comfort level. Not everybody's like you, and you're just wonderful.
It's also medical versus surgical approaches and fields.
Very different. Yeah.
Yeah. And again, a lot of what you're doing with your cardiologist, with your medical physicians, is primary prevention or secondary risk prevention, where we're trying to prevent events. We're trying to prevent you from needing the surgeon. We're trying to look at the screening, and the surgeon's trying to look at your repair as we need them to do.
Right.
And I see Anand had a question about how to fix an ascending repair endoscopically. That is not standard of care. That has been done through the axillary artery here, through the femoral artery. The restrictions in that are really where the coronaries sit. And there is more risk of stroke or dissecting up into the carotids or arch if it's not dissected into the carotids or arch. So that is evolving technology, and extremely exciting, but also still very risky at this point.
Yeah. Okay. All right. I want to let you go so you can have dinner, because I'm guessing you haven't had it yet, because you look like you're still in the office. But thank you again so much for taking the time to talk to the community, to explain all of this and show everything that you showed. And it's always such a pleasure to get a chance to talk to you. And I'm sure we'll talk to you again as we get closer to Aortic Disease Month in September. And I'll see you in like 14 days.
That sounds good. And happy Mother's Day to you and to all the moms.
Yeah,
there,
happy Mother's Day
to
to you
everybody's
too.
moms who are there.
Yeah, absolutely. All right, Dr. Fisher, thank you again. To everybody watching, please don't forget to click like, click subscribe, the little bell so that you're notified every time that we go live, so you don't miss a wonderful event like this. And thank you again for participating. Have a good night.